Welcome to the Rehab Links Secrets to Success podcast. I'm Lisa Chase, your host. And this morning we have Lee Burton with us. So welcome, Lee.
Thank you, Lisa. I'm really excited to be here. Looking forward to this. It should be great. With our long history, we should have a good time with us.
I know, I was thinking today, as I was driving in, I was like, God, when did I meet Lee? I feel like maybe we met. I know we met when I was back on the tour, and the WTA had hired you to kind of come in and help us with our physicals and looking at, some of the functional movement tests and how we can incorporate that in the physicals. And I think it was maybe back in 2003, 2004. So it has been a long journey, and we've worked together on that project and then continue to work together. I came on to help assist with teaching for SFMA and functional movement, so I'm very familiar with the systems. I use them every day and find them super helpful. So I'm looking forward to having you share your insights on how you've kind of evolved over the years, and how we're really using those systems to get our best outcome. So why don't we just jump in so you can give a little history about you. I know you're one of the co-founders along with Gray Cook and Kyle Kiesel. Was there a fourth person? I feel like there was a fourth person.
Yeah, Greg, Kyle, and I started it in a small clinic in Virginia back in the late 90s. Now we brought in and had some other guys join us, and I can kind of, Greg Rose has come on board over the last few years. Another one, Phil Plisky, who've all contributed as we've evolved. And, I'll give you the quick little elevator timeline here, Lisa.
Yeah.
Gosh, I had no idea it was back in 2003, but it sounds right. I think Gray and I, because back then we actually got to start doing some work with Reebok. And I think with Reebok, we were doing some testing with Venus Williams. And I think that may have been kind of the genesis to get connected with you. And I think one of your colleagues to do some testing, but to kind of give you the timeline, it's been a wild ride. We, Gray Cook and Kyle Kiesel and myself started in a small clinic, and, we never really had the foresight that we were going to create an education business and go around the world and teach and meet great people like yourself to help us continue to evolve. But we really started out with an idea. Gray literally came in the office, again, a small little clinic in Southern Virginia, and said, hey, we need to be doing some movement type based testing on high school athletes during the physicals. And that's really what started it. And I think today, a lot of people, and even I, Lisa, to be honest, forget kind of the genesis and tell the story. I was at a university doing a presentation a couple of days ago, and I asked some of the new students if they'd ever heard of the functional movement screen or even movement assessments, and 4 out of the 5 never had. So we've still got a lot of
really
well. So there's still a lot of work to do, but kind of getting back to the story. So that was the goal, was just to simply do as part of the high school physicals, and really determine what they were ready to do in the weight room. And I think, over the years, this kind of got spun into all these different things, but it was a simple little thing. Can you squat? Can you lunge? Do you have good upper body mobility, so that when you go in the weight room, you have the fundamentals to lift? So that's what started it. And then we gained some traction, kind of getting it out in the world, going out, really literally going wherever we could to kind of spread this message, to really get feedback. I mean, you go to university, speak at conferences, say, hey, we got this screen, we think there's something there. And lo and behold, it started catching on. We then developed our assessment that you helped us kind of teach. We started teaching seminars. That's been our business since probably 2005, 2006, teaching seminars. And really, fundamentally, what's been interesting for me along this journey, fundamentally, our philosophy's never changed. We need to look at movement. We need to think, make sure that we got the good fundamentals. How you look at movement, we've got our system, but Gray and I've always said, if you're looking at movement and have a system and a very methodical way to do that, that's fine. But we got to be looking at movement and figuring out what the underlying causes are. So we've been doing this since the late 1990s, and certainly have let research help us kind of continue to evolve. Fundamentally, the message hasn't changed. We continue to tweak what we do. And that's why I like, throwing things your way to give us some good feedback.
Yeah, and if I remember, and I don't know if it was Gray that told the story or you that I heard it from, but didn't he kind of write things out on a napkin? And it was like it kind of evolved from the very basics of, hey, here's an idea and let's write this out. And, and then certainly you guys have taken and really evolved it, where initially it was for helping in, like you said, the weight room, but now you've also transitioned into helping clinicians with the SFMA. And then I know you brought Greg Rose on, and like you said, Phil, where, he were pulling in that Y balance, testing. So, it's really now also helping clinicians. And then once, we get people moving better, then obviously then, okay, doing the FMS to get people back to sport or activities that they love. So I like the different systems and how it gives you a pathway.
Yeah, I think when we first started looking, we made a very concerted effort to call it a screen early on. Yes. That was a big debate. And as you said, Lisa, Gray literally walked in with a napkin and said, "Hey, I think we need to be looking at these movements." And Gray's pretty artistic. He had drawn out some movements and things. And, the squat was one, the lunge, we had the rotations. We had some other tests. But we really wanted to make it a screen because we didn't want clinicians to assume that this was a detailed assessment.
Right.
We've always looked at the screen as no different than looking at an eye chart. Look at your eye chart just to see where you are. And if you've got problems, we then need to do a deeper assessment. And one of the things that we found when we started really getting this out into, in front of more people, in front of more clinicians, is that they were using this as their assessment, this movement screen. And Lisa, as you know, the movement screen's tough. I mean, it's pretty difficult when we ask you to get you in certain positions. I mean, most of your listeners probably have seen or have done an overhead squat. Right. Well, an overhead squat is a tough thing to do.
Yes.
So we never really wanted the screen to be an assessment. We wanted the screen to help drive what maybe you should assess and what maybe you don't need to assess. And that's what made us really want to come up with the selective functional movement assessment, which is, again, assessing movements a little bit easier. But the SFMA really is there to look at some global movement patterns, but help to drive you to a very specific, what we look at as a movement diagnosis. What is your underlying movement problem? So it was really, the fact that a lot of clinicians were using the screen, which we really didn't want that to happen, and I shouldn't say forced us, but really led us to creating the SFMA and that logical system that it is today.
Yeah, and let's talk a minute about the SFMA, because I do think that is super helpful, right? To help you dive into, and like you said, diagnose movement and figure out, is this a mobility issue or a stability issue? And that is so critical. Even myself, years being, out and teaching at Michigan State, when I was introduced to those concepts, I was like, wow, I was trying to mobilize something that really needed stability. And it kind of opened my eyes, early on when I started taking the courses, and I was like, wow, this is a different way to look at things. So I think it's a really great tool for clinicians to help determine that, when should you be mobilizing versus really, teaching the stability piece.
And really, I think that's the hardest thing right there, Lisa, is I think we always gravitate. So for example, a good example is someone who can't touch their toes. People assume if someone can't touch their toes, it's a mobility problem.
Yeah.
Well, it could be a lumbopelvic stability issue, more of a neuromuscular problem that, in essence, the hamstrings are almost like a parking brake. They're acting like a decelerator trying to touch your toes, which they should, but maybe they're turning on when they should be, relaxing. And I think that disconnect is as you said, what I feel like we brought to the table. Most people can understand and get the mobility, and I think they understand how to improve mobility, but sometimes it's not a mobility problem. It's that underlying stability or neuromuscular motor control that we've got to tap on and reset that should then help things out quite a bit. So I do think that that's one thing we definitely opened the eyes of a lot of people. And quite honestly, I think, even today, all along in our world, whether you're a clinician or a strength coach or fitness professional, we've got all these tools for fixing things, but I think the diagnostics are really what's most important.
I totally agree, because honestly, I spend more time. I always say the mystery's in the history. So take a good history, do a good exam, and then it takes me 5 minutes to do a treatment. So, because if you do the exam and you do all those pieces at the front end, the back end's much easier, but otherwise you're chasing your tail. So I agree. I think that's really great. So let's get into getting great outcomes, because I know you've got lots of experience. So I thought you could share like 3, tips that you feel really over the years you've seen help to give you or clinicians that you've worked with, like Gray, Kyle, the best outcomes.
Yeah, I think the big thing, one of the first ones is, kind of what we just talked about, the old carpenter's, analogy of measure twice, cut once. And I think, as you just said, you kind of took the words out of my mouth, is, take the time up front. And again, nobody likes testing. Certainly the patient, they want to know how to fix my problem. And I think by taking that, a little bit more time up front, and kind of what I have felt helps, can help the most, is you're taking that time up front, but create some awareness or really educate the patient. Because it's nothing more frustrating, even for me, as we've all had some injuries, we've all kind of gone through this process, is, hey, my ankle hurts. Why are you worried about what's going on in my back or my hips when I'm in here for my ankle? And trying to explain, creating that awareness of why we are trying to do some things to the individual is really one thing that I felt is extremely important. To make sure that they you got to get the buy-in. And that's probably where I'm trying to get to with that is, yes, we can do the fixes and treatments. And I think that's also one thing, whether you're doing dry needling or, I've used a lot of leukotape and making someone feel better, but then taking that opportunity to say, yeah, we've got your ankle feeling better. That's the buy-in, but we really got to work on these other areas so that you don't continue to have this problem. And I think that's one piece that I feel like is extremely important and sometimes gets overlooked. And quite honestly, it seems to me today, and getting feedback from clinicians, we're not getting more time with patients. We're getting less time. Right. So we've got to figure out, still try to take as much time we can on the front end so that we know we can be efficient on the back end. So I think that awareness and education on why sometimes gets overlooked because we're so quick to dive in and just treat the area of dysfunction.
Yeah, for sure. Like you said, the patient comes in, they're like, okay, I'm in pain. How are you going to take my pain away? But, looking at the whole picture and the whole body is really going to give you the best, outcomes for sure. Yeah.
And then, the second thing, especially what I have felt like that has helped me over the years, is looking beyond just, kind of looking more holistically. I use this example right now back. I love this example because I do think it rings true. I was at a university for 15 years and worked, part of my responsibility as the director of the athletic training program was I also worked with, some of the athletes. And it was like clockwork. Every year, these athletes would come in, especially the freshmen, in the first 2 weeks, they would have the typical sprains and strains, strains, hip flexor strains, groin strains. And we're just getting inundated in the training room with those individuals coming in.
Yeah.
Well, back then, that's what I do. I'd stretch them out and make them feel better, kind of give them the thing. But looking back, not just addressing their physical, but also thinking about mentally, their lifestyle, all the things that happen to an individual coming in as a freshman, the changes that they are going through, the stressors that they have. They're not eating right. They're not drinking right. They just left all of their, significant others, their family, their friends, and get thrown into this new environment. I would argue that had just as much to do with a lot of their issues. And I think that's one thing over the last, say, 5 to 8 to 10 years that I have felt bringing that along with the diagnostics and the treatment, having those conversations. If someone right now, I believe if they're not sleeping right, they're not getting enough, fluids in their body, you're not gonna have the outcomes you need. And honestly, Lisa, even like I said the other day, talking to those younger professionals, we're just still not thinking that way. And I think that's one thing today that will help our outcomes just as much as some of the treatments we're doing.
I mean, that is so true. And you and I have talked about that. And, we implemented, been doing that for a while, and we implemented heart rate variability testing. And in our history, we are asking all these questions about nutrition and sleep and stress and how they're managing it, because really the nervous system gets overloaded, right? So if somebody is coming in with pain and they're in a high sympathetic load and they have all these other external stressors, sometimes just taking away those stressors and decreasing the threat to the nervous system without even touching the patient will help. So just bringing awareness to that and then giving them tools. I love having the heart rate variability assessment, because it gives me some numbers and I can then share that with the patient. And I know you guys are working on some cool, stuff as well, that allows the patient to self-assess and almost get a score to go, how am I doing on some of these things? And then when I'm feeling pain, hey, let's assess, hey, how was my sleep? Did I not eat so well? How was I managing my stress or whatever it was? And then if you just start to tap into some of those things and decrease the threat, all of a sudden the nervous system, kind of gets more balanced and people can get out of pain. So yeah, I'm totally on board with you on that one.
Yeah, that's why I like chatting with you, Lisa, because how you look at things is so similar. Again, looking at it holistically, looking at the neuromuscular system and how the nervous system, we're always trying to stay in homeostasis. And when we have pain, not getting into all the details of that, but that just disrupts everything.
Yeah.
And, it's going to create stressors in the body. And I think when we really, breathing is another big thing. Just trying to, control your breathing. When you're in pain, that's going to be disrupted. If you're not moving well, your breathing is going to be disrupted. And really, it's the chicken or the egg. So when they're in clinic, let's tackle both. Let's make sure we're monitoring their breathing patterning, but let's make sure, obviously, we got to take care of their pain. But one thing you touched on that was kind of my third, kind of thing is removing the negatives. One thing that Gray taught me early on, working with him, was we can't overwhelm. And too often we're always, in our profession, especially because I think the clients and the athletes or whoever we're working with come in wanting the fixes and wanting to know, how do I get better? What is the magic bullet, that you can give me? And I think sometimes it's better to remove certain things. Start removing. If talking about sleep, that sleep seems to be getting a lot of headlines these days, and the research has been around for years on how important it is. But instead of just talking about all the things you should be doing, think about the things you should not be doing. And I think that's that one, again, easy conversation you can have with your patients is, if you're not getting sleep, just simply, hey, try to make your room a little cooler. Don't drink any caffeine after 12 o'clock. Those are simple things that can have a big impact.
Yeah, that's very true. And yeah, I think, when patients go to therapists, I think oftentimes it can feel like adding more stuff, right? More exercise, more things for them to do. But yeah, that's a great point. Like, what can we take away that is actually going to enhance, that overload to the nervous system? So yeah, that's great.
And Lisa, that's tough. I mean, when we develop this is totally gets lost over the years, but it's been part of our methodology or philosophy since day one. When we developed the movement screen and we said, let's make sure these athletes are prepared to go into the weight room, our first thought was not correcting the patterns. It wasn't about corrective exercise. It was like, if this athlete cannot do a push-up, they should not be bench pressing. If they've got poor shoulder mobility, we shouldn't be doing overhead presses. And even today, that's still where we start. It's removing exercises, and then we can get back to, okay, now we got to fix the problems. But even, again, with something like low back pain, yeah, you can prescribe an exercise or a treatment, but if you're not thinking about things that are causing their back pain and try to remove them, whether it's their diet, whether it's their sleep, whether it's their stress in their life, your outcomes are big. Maybe they'll be short-lived.
Yeah. Yeah, absolutely. You know, be temporary. So that's very true. So I know you go around the country and around the world actually teaching. So what would you say are, you know, some advice that you can give, like that your audience really appreciates, like after you're teaching, or the questions that you're getting, or the aha moments that your students are having? Like share some of those that you get through your, you know,
Oh,
experience.
yeah, Lisa, that's a tough one. Yeah, I'd say, you know, the aha moment is, well, the feedback I've gotten over the years is, you know, I'm not going to tell you, Lisa, or any professional how to treat or how to do your job. We're trying to give you some guidelines. And I think that's what most people, when they sit down in our seminars and we get done educating them, that's what seems to be refreshing is, hey, I'm not trying to tell you how to treat your patients. I'm not there with you. Everybody's different. But here's some simple guidelines, some simple things to consider, and don't try to do everything at once. You know, try to, you know, when they sit through a two-day seminar, they go back Monday and their heads are spinning. Hey, ease into it, get a little practice, and you know, if you keep coming back and keep trying to revisit it, you know, some of these basic rules and thoughts that we're talking about, easing them into your patients or trying them on some friends. You know, don't take your worst patient on Monday after going through a seminar and trying to implement some of these things. Your friends, your colleagues, you know, try some of those things. And again, I think the biggest piece of feedback is the fact that Gray nor I or anybody in the FMS world is trying to tell you what or how to teach. We're trying to give you some guidelines on movement that you can hopefully implement. And I think that's one of the biggest things. And at the end of the day, the other thing, Lisa, as you said, I've been very fortunate to travel around the world and talk to so many different people. At the end of the day, most everybody's the same. Most everybody's dealing with the same situation, right? The same problems. So we don't necessarily need to think too differently. We're all human, and we're all trying to help the people we work with.
Yeah, you know, and look, at the end of the day, like you said, it's a tool, right? It's a tool that, if used, can help make your life easier, because you're going to be able to figure out what your movement diagnosis is, and then what's the best treatment strategy. And then, you know, you can go like to dry needling, and we can go to Michigan State and do the manual stuff. And so, you know, you can learn all these different pieces. But the key is, and we also teach that at Michigan State, is getting to the fundamentals of where do you start, right? Because how do you unlock the system? And the magic is really in the stuff that we're talking about today. So yeah, that's good.
Yeah, you're right. So, you know, it goes back to being able to diagnose, figuring out what you need to work on, and then bring whatever tool, whatever you feel like is going to be the best way to improve the movement dysfunction that we found. It could be any number of things. It could be an exercise. It could be, you know, maybe get them sleeping better. It could be dry needling. It could be some manual work. But I think the other piece that sometimes gets overlooked is going back and rechecking. I think if you create the systematic model with which to look at movement that we're talking about today, you've got to be reliable. You got to do it. You got to follow the rules to start, so that when you do your treatment and you go back to get the right feedback to see, did this work, you can feel confident that you're getting the right results. So there's two things there when we start looking at movement. One, we're trying to figure out what we need to work on, whether it's a mobility or stability problem. And whatever you bring to the table to quote unquote fix that problem is up to you and what your expertise is. However, the only question I would have is, all right, did you go back and recheck? Did you confirm that what you did had the positive feedback that you want? Because if it didn't, okay, fine. Then doesn't mean the treatment's bad. It just didn't work on that person. Try something different. And I think sometimes that's one thing that also gets overlooked. We may make an assumption because I did some dry needling on this patient and it worked. Well, I can't assume that it's going to work on the next patient. Go back and recheck. And I think that's an important piece.
I think that is really important. And I think being honest with yourself enough to say that didn't work, you know, like you said, and so then let's try something else, versus being like, well, okay, you know, you want to kind of learn from it. And you're right, like every patient is different. And so what works on one may not work on another, because that one switch, is going to work and another is, is not going to be as effective. So yeah, you gotta test and retest to know if you're really making a difference. And I really think it also brings awareness to the patient. Like you talked about, patients don't like, you have to do all this evaluation, but when you're like, oh, look, you remember when you couldn't do this when we first started, and now you see how that's moving easier, or see how you can touch your toes now, or they get an aha, we're like, oh my God, I can touch my toes now. So it also brings that awareness to the patient, which is great, because they see, oh, okay, there is a change happening, then they start to get, that hope of, okay, I'm going to get out of pain and I'm going to feel better and move better.
Yeah. I mean, that is the aha moment with your patients. And even for me, taking somebody that has let's say they got some tightness in the posterior chain, you get them on the ground and just have them do some breathing drills. They get up and they just touch their toes. You've got a client or a patient that really wants to know, give me more, give me more, give me more. So it is those types of things, because I think if we're trying to, in my opinion, the stability or motor control areas that are problematic, we can hit reset on those and get some pretty quick positive feedback on those things. And I think if we can tap the right switch, as you said, we can make some changes pretty quick.
Yeah. And I don't know about you, we've both been doing this a long time, but I still will be like, get excited where I'm just like, look how that works, it's just like, so it's fun.
It really is. I mean, especially, teaching a seminar, and
I'm sure you see it all the time.
Yeah. Teaching a seminar for as long as I have, like you said, I still get excited when I do something that works and works in front of a group. I'm like, oh, hey, this stuff works. It's not
right. Exactly.
We've been doing it a while, but it actually does work.
That's awesome. Now, I'm not sure if you wanted to touch on any of, the stuff that you're currently working on. Did you want to share any of that?
Yeah. One thing that over the years, as I said, we've there's been research. I mean, to be honest, Lisa, I think right now, last I checked, and one of our colleagues did a research review, between the Y balance test, the SFMA, the FMS, there's probably 600 to 700 referee journal articles on the functional movement screen in all of our tests.
Right.
And, when we start, one of the things that we got, I guess, positioned as early on was, is the FMS an injury predictor? And there's a lot of research, and some research says in populations it is or it isn't. And that's fine. We've been looking at the research and trying to let the research help direct us. And that's one reason, a number of probably 3 or 4 years ago, we added an ankle mobility screen into the functional movement screen. We realized, because of what the research was telling us, we weren't screening effectively the ankle. And the ankle consistently was showing up as an injury risk factor. So that's an example of us making some changes based off some of the research. And here's the big one. And Lisa, you've been great to help us test this out over the last probably few years. Back in 2015, 2016, we did some research with the military, a large military study, and started looking at what are the risk factors that create injury risk. What can we eliminate? What are the things we don't need to worry about? What are the things we need to worry about? And what we were able to do is put people in high risk categories to low risk categories. And really what the research told us is kind of what research does. It just proves what we already knew. And the more problems you have, the more likely you are to have an injury. Meaning, just like we talked about, if you've got a pain with movement, if you got some asymmetries or dysfunctions, if you got a lack of ankle mobility, if you have a balance problem, those were the things we're seeing. Now, all of us have 1 or 2 problems. Nobody's going to be moving perfectly. But what we started seeing is, okay, if I've got 1 or 2 problems, I'm probably okay. But if I've got 5 or 6 of those problems, I'm at high risk. So we actually started looking at it. And then we started seeing all the other risk factors based off lifestyle, as we just talked about: sleeping, breathing, what's your stress and stress recovery right now is just huge, hydration. So all those other factors. So what we started doing, we had that algorithm for high risk, low risk. We started playing around with the algorithm, and we said, all right, we need to look at movement, but we can't, if we really want to be proactive. And I think that's what we're all trying to be. Let's be proactive so that we try to reduce injuries, even in a patient who may be leaving us. We're getting ready to discharge them. Let's set them up for success because as clinicians, we all know once you get one injury, once somebody comes in with low back pain one time, we can send them out the door feeling good, but it's a good chance they're going to be back. So how do we set them up for success long term? So what we started doing is we started looking at how do we give the individual some tools so they can self-assess based off of all these factors. So now we're actually doing that right now. We're coming out with a way for a person at home to screen themselves, as well as create an algorithm and a platform for clinicians to start looking at movement as well as breathing and some of their lifestyle, their stress, all those things. So we're trying to put all that together so that we can look a little bit more holistically and tackle some of these musculoskeletal health problems.
Yeah, and I've started to test it out myself, and I just sent it to my whole staff. And I would definitely, we talked about adding it to our patients, as they're moving more onto a maintenance program. How do we give them those tools so they could be self-assessing and then coming back in for those checks, or if they are showing up as high risk, bringing them in sooner rather than later. So it's a nice I think way for them to take control and and implement some change.
Yeah, and that's one thing that I feel like our main goal with this tool, by empowering the patient or the individual to self-assess, that goes back to that awareness and education. And let's be honest, Lisa, we're looking at movement, we're looking at a lot of these gauges we're looking at, they're nothing but a snapshot. It's always going to go up and down. It's a roller coaster. Life gets in the way, whether I go out and play golf this weekend and I tweak my back, or whether I stay up too late and have a few drinks. The next day I'm not going to feel as good. So things are always changing. So giving an individual, for example, you look at heart rate variability, the same thing. It's going to go up and down. That's only going to give us and hopefully the patient some more insight in what they need to be doing.
Yeah, absolutely. Yeah. Great to give them tools. And I love that. So I'm excited, to eventually share that with patients. So thanks for, you guys working on that and having me be a part of that, so I can, see how it's going to actually work in real time. So
exactly. Yeah. Just because I think it's going to work doesn't mean it is.
I know you gotta test it out, which is good, which I love about you guys. You always are, testing things out and before you bring it to the market. Well, this has been awesome. So let's now tell the listeners, I know we're going to put some of this in the show notes, but how they can find you. And I know you're going to extend an offer. So let's just talk about that. And then we'll have everything in the show notes for people to access.
Yeah, we teach courses all over the world. We teach virtual, we teach live and online. Definitely extend some discounts to all of our online education. And one thing that we do that I think is unique, if you take some of our online education, maybe the SFMA or the FMS, you can then show up to a live education at no charge. So if you pay to take the course online, which is what I recommend, take it online, then try to get to one of our live seminars. So we'll put some discounts in there for you for that. But if you go to functionalmovement.com, you can get some more insight. And if you go to, we'll put this in the notes as well, Symmio, SYMMIO.com. That's what Lisa and I were talking about, our new little project. Haven't really released it yet, but you guys can take a look and maybe reach out through that website. There's a contact page in there to maybe get more insight into what we're doing with that. But I can't thank you, Lisa, enough for being such a loyal friend and allowing us to share some of our new things with you and you give us some honest feedback. And thank you for having me on today.
Well, absolutely. It's always fun to reconnect after all these years. And I would, highly recommend to any of the listeners, if you haven't checked out their online, courses and just lots of resources. I know you guys have put out, tons of stuff, which is just, I've used and continue to use over and over again. I would just highly encourage you to, check it out. It's a game changer, and I'm always looking for good game changers. So thanks for that. And until next time, keep getting great outcomes.